Welcome everyone to this 17th session of the OESO-SEMPIRE virtual educational channel. And now I will hand it over to Robert for the introduction.
Thank you, Frederic. Before presenting this 18th session proposed to the scientific community by the OESO-SEMPIRE platform that you can see behind me, I would like, first of all, and on behalf of our colleagues from OESO and Stanford Health, to upload today, before our discussions, the presence among us of the one who in March 2018 in Palo Alto took part in the launch of the OESO-SEMPIRE platform, along with Professor Mao, already there, and other Chinese colleagues. This was in Palo Alto in 2018. The one, Professor Jie He, who chaired the 15th World Congress of OESO in Beijing in 2019. Here you can see the inaugural and opening ceremony of this Congress. Professor Jie He, who shared our enthusiasm in welcoming 6 major Chinese universities to be added to the center of Beijing, as you can see behind me. And Professor Jie He, who is doing us the honor, the great honor of opening this session. Professor Jie He, with his countless titles recognized the world over, among which Director of the National Cancer Center in China, President of the Beijing Cancer Hospital, representative of the Asian countries in the advisory board of the platform, and providing us with the support of the Chinese Academy of Medical Sciences. We, the OESO Foundation, and the whole SEMPIRE platform are extremely glad to welcome him among us today, and I hand the floor over to Professor Jie He for a special address.
Ladies and gentlemen, dear friend from China and other countries, good night. Welcome of all of you to participate in this OESO Global Cloud Meeting on esophageal disease. It is my great pleasure to make an opening speech on behalf of all of my Chinese colleagues. Before starting the second Global Cloud Meeting on esophageal disease, organized by OESO and Beijing, Shanghai, and Guangzhou pilot centers. In recent years, chemotherapy combined with immunotherapy followed by minimal invasive esophagectomy for locally advanced esophageal cancer is getting more and more popular around China. However, fatal advanced events occasionally occurred, and a disease further investigation and more attention our colleagues and going to report 2 interesting cases on management on immunotherapy-induced pneumonia and removal of esophageal foreign bodies. Hopefully, this global cloud forum could provide an excellent opportunity for us to share experience in the management in this field. Finally, I wish this global cloud meeting a success and all of you a good time. Thank you.
Thank you, Professor Jie. We all applaud Professor Jie He's address, looking far into the future. Now, this 18th session of clinical case discussion is today in line with the mission of the OESO-SEMPIRE platform of excellence in esophagology. This time, 3 of the platform's pilot centers, those of Beijing, Shanghai, and Guangzhou, have joined forces to offer you the opportunity to discuss the cases of 2 patients chosen for their particular educational interest. In this spirit, these 3 centers have made a very special effort to organize this session. As you will see, each of the 2 cases, each of these cases will be presented first by 2 members of one of the pilot centers. That of Guangzhou, Dr. Hong Yang, here you can see him, and Zerui Zhao, can see him for an esophageal cancer. And the second center of excellence, the pilot center of excellence in Shanghai, with Dr. Liji Tan, 7, and Songwei Chen for an esophageal perforation, very interesting and particular case. Then the discussion will be led by 2 moderators. The first one by Professor Yusheng Mao from Beijing for the first case. And then Tao Yu, excuse me if the pronunciation of your name is not perfect, but I will have to get more lessons from Nicolas and his wife. So the second one with Dr. Zhang Taoyu from Shenzhen for the second case. The discussion itself will involve a large number of young specialists who will also intervene from the panel. There will be Dr. Yang Tao Han from Sichuan, Zhifeng Liu Le12 from Hebei, Yan Li from Beijing, and Xinghang Li from Shanghai, with Dan Wang from Beijing, all these for the first case. And the discussion from the second case will involve Kenneth Chen from Beijing, Wen Tao Fang from Shanghai, Xufeng Lang from Sichuan, Liang Dai from Beijing, and Xufeng Guo from Shanghai for the second case. And to these panels of our Chinese colleagues will be added, as usual, an international panel who will comprise today Dr. Stéphane Bonnet from Paris, Stéphane Monig from Geneva, head of the Pilot Center of Geneva, Michael Mwashiro from Bomet, Kenya, who is sharing with Professor Russell White, the COSEXA Center in Bomet, Kenya, Professor Eduardo De Moura from Sao Paulo, and Professor Matthew Reed from Melbourne in Australia. And then, to summarize the mass of information resulting from each of the 2 discussions, 2 young specialists agreed to play the difficult game of synthesis. There will be Dr. Jianhua Fu from Guangzhou and Liji Tan from Shanghai. And you have already noticed on the newsletter of announcement that you received, and as you will see, the iconography presented has been very, very carefully chosen by all the presenters to make the discussion as interesting as possible. And I hand over to Professor Yusheng Mao, our friend from Beijing, with Professor Jie He there, for a few words of introduction of the first case. Professor Yusheng Mao, please.
Okay, thank you. Thank you for your excellent introduction of all our Chinese colleagues. And I would like to invite Dr. Chen to present the first case from Guangzhou Pilot Centers.
It is my great honor to kick off the virtual discussion tonight. I'm Dr. Zhao from Shanghai University Cancer Center in Guangzhou. And the case I bring here tonight is the immunotherapy-related pneumonitis following neo-adjuvant chemoradiation plus PD-1 inhibitor in a patient with locally advanced esophageal squamous cell carcinoma. So the patient was a 61-year-old female who found a lesion in her lower thoracic esophagus by an endoscopy in a routine checkup. And the biopsy confirmed a squamous cell carcinoma. The baseline EOS showed that the tumor was located from 31 to 35 centimeters from incisors invading the musculatus proprius, and 2 paraesophageal lymph nodes were suspicious of lymph node metastasis. So all this lead to an increase of the baseline staging with T2 and 1. The CT scan also showed that the tumor location was below the level of inferior pulmonary vein. The cardiopulmonary function was basically normal. The lady then signed a consent for participating for a phase 2 trial investigating the feasibility of PD-1 inhibitor polipalimab with concurrent chemoradiation for esophageal cancer. So according to the protocol, the lady received a 44-grade radiation in 20 fractions over 4 weeks with paclitaxel and cisplatin given weekly simultaneously, and 2 doses of PD-1 inhibitor was administered on day 1 and day 22. And the preoperative treatment was carried out uneventfully. And from the EUS after the treatment, we can see the tumor shrinkage and mucosal scar formation in the lower thoracic esophagus. The CT scan was also carried out again to rule out any surrounding organ invasion. We also arranged an EBUS test to evaluate the status of the subcarinal lymph node. From the transbronchial needle aspiration result, we can find some typical cells suspicious of plurally differentiated carcinoma. So we decided to perform the minimally invasive material esophagectomy after around 8 weeks after the completion of the neo-adjuvant treatment. And interestingly, the pathological result told us that there was no evidence of tumor residue in both the primary tumor and the resected lymph nodes, including the subcarinal lymph node I mentioned before. So actually, the patient achieved a pathological complete response after the neo-adjuvant treatment. But unfortunately, the lady experienced an respiratory dysfunction postoperatively. And from the ABG test, we can find the type 1 respiratory failure, and the patient require mechanical ventilation from postoperative day 2 to day 7. And the symptoms of dyspnea did not reveal following antibiotic treatment after weaning the ventilation support, and we can find some progression of lung effusions from the chest X-ray, but there was only a mild elevation of white blood cells and procalcitonin in several parathesis. So we arranged a CT scan for the patient, and the result turned out to be bilateral lung effusions, indicating the existence of pneumonia. But the sputum cultures in several times failed to find any specific pathogens for this pneumonia. For this reason, the MDT specialist in our institute suggests that the patient might have an immunotherapy-related pneumonitis. According to the textbooks, the symptoms of the ICI immune checkpoint inhibitor-related pneumonitis can be non-specific. And the feature here demonstrates 3 typical radiography findings, including the non-specific interstitial pneumonitis and the organizing pneumonia, which is also the most commonly found pattern of this kind of disease. And the last one is diffuse alveolar damage, which is also the case we presented here. And given by the respective guidelines of treating this kind of disease, the lady was grade 3 adverse events associated with immunotherapy, and intravenous prednisolone in a dose with 2 milligrams per kilogram daily was given intravenously and weaning slowly in the following 10 days. The symptoms of the patient was relieved subsequently, and the CT scan 10 days after the administration of prednisolone showing a remarkable clearance of the diffuse alveolar damage. Then the patient was discharged 2 days and recovered uneventfully 6 months in our outpatient visit center. So this is the outline of our case here. Thanks so much for your listening. I shall give the microphone to the moderator, Professor Yang, please.
Hello. Thank you very much. Thanks to Dr. Zhao on the very excellent presentation of case 1. And this is a very interesting case. So even though you reported it very clearly, but I still have some questions to ask you and Professor Yang. And the first question is, did the patient have the EBUS TBNA for the assessment of loads before the advent chemotherapy combined with PD-1? And the second question is, when did the patient begin to have a short of breath after surgery? I mean, just after the surgery in the post-operative first day or the second day? And the third question is, why did you suspect that this patient had a immunotherapy-induced pneumonia? What is the evidence? And the fourth question is, how much is the incidence rate of the immunotherapy-induced pneumonia in your cohort? So maybe too many questions, and I would like to ask Professor Yang and you to give all of us a explanation. Thank you.
Thank you, Professor Mao. It's my great honor to have this opportunity to join the OESO virtual meeting. So you offer me so many questions. I will try my best to share my opinion. So first is that the EBUS needing biopsy, lymph node needing biopsy. You may notice that before the surgery, you perform the EBUS needing biopsy to the subcarinal lymph node. But in our clinical work, it's not our routine work. So before the treatment, including the neo-adjuvant treatment, we don't perform the EBUS biopsy to figure out whether the subcarinal lymph node is metastatic or not. But we judge by the CT scan under EUS to make the judge of as to the diagnosis whether the patient has the regional lymph node metastasis. Because for this patient, CT scan and the EBAS show the highly suspected of regional lymph node metastasis. So before the treatment, we think the end stages N1. Another question, why do we perform the EBAS biopsy? Because it's another clinical trial in our team. We are investigating the effect of using EBAS to evaluate the status of the subcranial lymph node. So it's a clinical trial. So the second question is, sorry, I don't remember the second question.
When did the patient begin to have
when did the patient?
breath?
So very short answer. The second day. The patient has checked out from the intensive care unit and transferred to our department. On the second day after the operation, the patient happened to have the dyspnea and getting worse. And then we take the blood gas. The blood gas and the chest X-ray show the patient has the respiratory failure. Then we transfer the patient to the ICU and offer the patient the intubation with the mechanical ventilation. Second day. Thank you. So the third question is the diagnosis. Yes. So it's also a challenge for us because we all know that for this patient belong to the locally advanced esophageal cancer. So up till now, the standard therapy should be neo-adjuvant chemoradiation followed by surgery. But because we are our center, we are also conducting a phase 2 clinical trial investigated the effect of neo-adjuvant chemoradiation plus immunotherapy. So this patient has been enrolled in this clinical trial. So he received the immunotherapy. So at the we don't have much experience about this situation, about the ICI-related pneumonitis. So at the beginning, we don't consider ICI-related pneumonitis. We think it's more possible the patient should have the lung infection or pneumonia, normal pneumonia. Then we give the patient mechanical ventilation and the antibody treatment. And the patient, I think the lung function recovery, because after a week of treatment, the patient went the ventilator, and then he checked out from the ICU. But in our department, the patient still has the symptom of dyspnea and need oxygen 3 to 5 liter. And from the chest rate, especially the left lower lung, the haziness didn't recover. And then we begin to wonder why the patient still had the problem. So at this time, we still don't suspect ICI-related pneumonitis. We think it might be radiation-related pneumonitis. Then we consult the specialist from the radiotherapy department, and they check the radiation plan, but they tell me that it's not the radiation-related pneumonitis. And then we consult the specialist from the pulmonology. And that time, because we exclude the pneumonia and the radiation-related pneumonitis, then the last one, we wonder it could be the ICI, the immunology-related pneumonitis. Then we try to use the steroid. Radiologically, the patient recover. You can see the diffuse alveolar change clear in a way after weeks of steroid treatment, and symptom of dyspnea relief, and the patient check out just after 1 week of steroid treatment. So when we make some summary, recall the progress of the patient, we think it more possible that it should be related with the ICI-related pneumonitis.
So how much is the incidence of your cohort in your clinical trial?
Yeah, thank you. So we have some preliminary data because we have completed the patient enrollment in our trial. We enrolled 44 patients in this trial, and 42 patients complete the full protocol, receive the surgery, and 2 patients, we think 2 patients have their ICI-related pneumonitis.
Okay, okay, thank you very much. I see Professor Morning raised his hand. He would like maybe have some a question for you or wanted to have some comments. Please, Professor Morning.
Thank you very much. It is a very interesting case, and I would like to congratulate you for the management, the surgery, the diagnosis of the pneumonitis, and the treatment. I have few questions, three of them. First, you don't mention the control of the anastomosis. Do you routinely perform CT scan to be sure there is no anastomotic leakage? It was the first question. The second one is, how long was the duration of the corticotherapy? I mean, 1 month, if I have well understood. And the third question is about the PD-1 inhibitor. So your trial is a phase 2 trial, very interesting, where you can use toripalimab, the PD-1 inhibitor, with neo-adjuvant chemoradiation. And we know, in fact, that after chemoradiation, there is approximately 20 to 40% of patients for whom there is no longer tumor after chemoradiation. So in France, we are going to use very soonly, I hope, the protocol Checkmate 577. I'm sure you know it. And the advantage of such a treatment is the PD-1 inhibitor is used after surgery, so that we don't have the complications of the immune checkpoint inhibitors related pneumonitis as you have. We don't have such a complication around surgery. What do you think about this Checkmate 577? Did you have used it, and what do you think of that? And again, congratulations of this case.
Thank you. Thank you for a comment, Professor Bonnet. So the first question is sure. Thank you for additional suggestion. It's very correct because at the beginning, especially for the patient with esophageal cancer after surgery, if the patient has ARDS or respiratory failure, we must exclude whether there is anastomosis leakage. So on the third day after the operation, when the patient has the intubation ventilator, we perform the endoscopy for the patient to exclude the leakage. And the second question is the duration of the steroid. So the time length is around I remember 12 or 13 days because at the beginning, we used the dose of the prednisolone 2 milligram per kilogram, and just maintain this dose 3 to 4 days, and the symptom clearly relieved also with the chest X-ray, and then we decrease the dose and take the prednisolone for 7 days to the 20 milligram per kilogram, and then stop it. So the third question is that, so I would like to explain that our clinical trial, we call it NewTech 1901, because we start the trial in 2019. We know that the CheckMate 577 report is dated in 2020, I remember. So at that time, the new adjuvant immunotherapy has not been added in the guideline. But our hypothesis at that time is we are going to try to figure out another direction or another modality to further improve the patient's prognosis. Because our center also conducted the NewTech 5010, because that trial, the data also identified the neo-adjuvant CRT is better than surgery alone. So we try to do plus way to add the immunotherapy into the neo-adjuvant chemoradiotherapy. In that phase 2 trial, our primary endpoint is PCR rate. We hypothesized that we could increase the PCR rate to 50%. And at the end, we found the PCR rate is 52%. So it satisfied, it achieved our goal at the beginning. So that's the situation of our trial. Of course, nowadays, immunotherapy has been more and more used in the adjuvant therapy, especially for the non-PCR patient. And in our clinical work, we also carry out this policy. So that's the condition.
Thank you very much. Thank you very much.
Welcome.
Okay. I noticed the Professor Stephen Morning from Geneva. Do you have question or any comments? Hello? Okay. I would like to invite some Chinese colleagues to have any comments. Professor Junfeng Liu, are you there? Professor Junfeng.
Thank you very much for giving me the opportunity to discuss something about immunotherapy-induced adverse event. As we know, immunotherapy for cancer is becoming popular in recent years, especially for esophageal cancer, because there is no molecular targeted therapy for esophageal cancer. Some immunotherapy results are encouraging. It usually results in very high MPR and PCR, just like this case, immunotherapy resulted in PCR in both primary cancer and resected lymph nodes. But whether higher MPR and PCR can benefit long-term survival, we should wait and see. Another issue that cannot be ignored is the worst event induced by immunotherapy. Just like these patients, very severe pneumonia occurred in the first post-operative week. Fortunately, this patient eventually recovered after proper treatment. I think that this very interesting case tells us the experience that extensive bilateral pulmonary effusion is the main CT finding, and the effective mechanical ventilation and the use of prednisone are the key treatment for immunotherapy-induced pneumonia. The last, I also have two questions to ask Professor Yang Hong. Yeah, okay. The question number one, in addition to immunotherapy, do you think operation itself is also the component of risk factors inducing pneumonia? This is the first question. The question number two, are there any measures can be taken to prevent immunotherapy-induced pneumonia? Thank you.
So the first question, thank you, Professor Liu. Yes, I agree with you. I think it's combined factors, complex and cause the result. Of course, I think chemotherapy, radiotherapy, and surgery trauma and immunotherapy. They are 4 important factors to cause the postoperative progress of the patient. If the patient just received chemoradiation, I think, or chemoradiation plus immunotherapy, because the immunotherapy, you may notice, only 2 cycles. So if the patient did not receive the surgery, I think he may not have the pneumonitis. The second question is,
measures can be taken to prevent immunotherapy pneumonia.
Yes, thank you, Professor Liu. It's very interesting. Although we have a few experience, up till now, we happen to do case of patient with pneumonitis, but we do pay attention. We are cautious, very concerned about this situation, because once it occurs, it may cause disaster result. So nowadays, for the patient may in the clinical trial, we will take some measure. We think it could help us to prevent the ICI pneumonitis. We will we will control the intravenous volume, and sometimes we will give the patient the globulin, gamma globulin. We think this measure could decrease the inflation level of the patient so as to prevent the ICI-related pneumonitis.
Okay, thank you.
Okay, very good.
Thank you.
Okay.
Well, Dr. Mao, this is Vincent Fang. Can I ask a question?
Okay.
Sure.
You're welcome.
Thank you. Dr. Yang and Dr. Zhao, thank you very much for your excellent presentation. And this is a very interesting case. I think it's a very a useful discussion for future practice. My question would be, what kind of ventilation did you use during surgery for anesthesia?
SIMV.
SIMV? During surgery?
Anesthesia. During surgery, you mean?
I'm sorry, I think.
Oh, during the surgery. Oh, sorry.
Double room and intubation.
That's a single lung ventilation, right?
Yes.
Yes.
So it seems to me that most probably this is not a immune-related adverse event. It's just an acute lung injury after surgery. Because we all know that esophagectomy is a very complicated case. Usually it takes a very long operation time. And if you use single lung ventilation, there's a high probability that the contralateral lung, the left lung, would be injured during anesthesia. So in this case, this patient actually had inflammatory change to the left lung instead of in both lungs. And the treatment to acute lung injury and immune-related adverse events are actually the same. So the patient's response to steroids doesn't necessarily mean he had immune-related, pneumonia. It's not a pneumonia. It's not immune-related, adverse event. It's just an acute lung injury after surgery. That's my speculation. But anyway, congratulations on the good result. Thank you.
Thank you. Thank you, Professor Fang. Yeah, it's very interesting. You do remind us, and partly I do agree with you, but I think nowadays because we all perform the MIE MACU, and because using the thoracoscopy, usually the thoracic part take around 1 hour, even less than a vasculotomy. But I think it could possibly by the you mentioned ventilator lung injury, single lung ventilated injury. but also it's very rare. And for this patient, we just noticed when we use the routine method, use the broad spectrum antibiotics, even the patient can win off the ventilator, but from the radiology, you notice the left lung haziness just did not recover. But when we use the steroid, it clear very soon. Thank you.
Yes, immune-related adverse events and also acute lung injury would both respond to steroids. That's why your patient did not have inflammatory changes on the right side. It's not your fault. It's your anesthesiologist who probably had used the higher pressure ventilation that caused a ventilatory pneumonitis. I think it's very important to communicate with your anesthesiologist in the future so that they have a lung protective ventilation strategy. In that case, you will have less and less such events in the future.
Thank you, Professor Fang.
Anyway, congratulations. It's a nice case, very educational. Thank you.
Thank you.
Yeah, great thanks to Professor Fang. You remind us of another way to think about this pneumonia. Maybe surgery or ventilation have some side effects to this pneumonia. Okay. And there are any other foreign professors? Hello?
Yeah, may I have comments?
Professor Li, okay. Do you have any comments?
Yes, yes, congratulations, because the patient's life is saved. Either it's immune-related pneumonia or just ventilator-related pneumonia. So this is a very classical and, of course, a cutting-edge case of patients receiving the neo-adjuvant chemoradio and immunotherapy. So the induction immunotherapy is very hard in China, but in Western world, sure, the cross surgery and technique 577 is another track. So actually, I have the same question. So like Dr. Fang, the immuno-related pneumonitis, it didn't happen during the immunotherapy, and it didn't happen during the waiting time, but it happened during operation. So this is why my question, why it happened so late? Because I have maybe more than 200 cases with the induction immunotherapy. So usually we found that the immuno-related pneumonia happened during the first cycle of the immunotherapy. So it's very, very common duration, but not so late. So my question is why these patients, the so-called immuno-related pneumonitis happened during operation, but not before. So this is my question. So maybe do you think the surgery is a trigger for this pneumonitis? So this is the first question. And the second question, what about the difference between the induction chemoradio and induction chemoimmuno? So maybe it's different because according to our previous retrospective study for the nationwide of China for the induction immunotherapy, we found the radiation with immune together can increase the complications dramatically. So maybe this is a key point for this patient undergoing the immuno-related pneumonia. So this is my second question. So what do you think about the the radiation during the induction course? And the third one is not a question, actually it's comments. So I like Dr. Boney's comments. So maybe the checkmate 577 give us another idea for the for the esophageal cancer treatment. Maybe the induction chemoradio we served is safer than our current effort for the induction immunotherapy, because it actually could be safe. Because in the cross trial, the totally treatment-related deaths, there's only one patient. So it's very, very low. So maybe the induction chemoradiation with surgery is safer, and with another, maybe the checkmate 577. And because during that operation, we can see the distant metastasis is decreased dramatically. So it's a safe induction therapy and surgery with a very safe adjuvant immunotherapy could be reasonable in the future. These are my comments. Thank you.
Thank you, Professor Lee. So the first question, I think, I could only share the data from the clinical trial about the immunotherapy used in the late stage of ESCC or other tumor. I think usually the ICI-related pneumonitis will occur from 2 weeks to 3 months is the median duration. But I do agree that surgery is another factor that could stimulate, could cause the pneumonitis. Because we know that the mechanism of the ICI-related pneumonitis is the increased T cell activity and enhanced inflammation. So all the factors that could increase the inflammation may be the reason for the pneumonitis. But in our clinical trial, we enrolled 44 patients, but no patient had pneumonitis during the chemoradiotherapy plus immunotherapy. 2 patients all occur after the operation. So the second question is that about the chemoradiation 577. Yeah, I agree. For the patient, a non-PCR patient, I think immunotherapy, adjuvant immunotherapy is useful. But because in our data, in our phase 2 clinical trial, we think that maybe using the neo-adjuvant chemoradiation plus immunotherapy, we could increase the PCR rate from 30 or 40% to 50%. From this direction, I think that we could possibly further improve the patient's prognosis, because from our data of NeoTAC 5010, the PCR patient, the 5-year overall survival rate is 82%. So we also notice another interesting situation is that after neoadjuvant immunotherapy, the percentage of patients with N positive has been significantly decreased from the historical data 30%, and in our phase 2 clinical trial, the N positive patient, the percentage is only 12%. 12%. And we also know from the NeoTAC 5010, for the patient with N negative, the 5-year overall rate could be 72%. So I think that we are still interested in carry out the clinical trial in this neoadjuvant CRT plus immunotherapy. As to the safety, compared with the historical data from NeoTAC 5010, we think no significant difference between 2 combined modality. Of course, there is some unit like ICI-related pneumonitis, but the mortality in this trial is also 0. So maybe I have another idea, interesting idea, that if we could increase the PCR rate, then fewer patients will need to receive the adjuvant immunotherapy. That may also decrease the treatment side effect and treatment cost. So that's my opinion. Thank you.
Okay, thank you. So I think we need the future clinical trial to compare these two checked.
Yeah.
There's
Okay.
no RCT study for this idea.
Thanks to both of you, and some professor also have their comments. Professor Michel Maro from Kenya, are you there? Hello?
Thank you. I'm here. Hi. Hi, everyone. Thank you. That was a great presentation. I really enjoyed listening to that, especially since we are now seeing the possibilities of having immunotherapy even here in Kenya. So I have two questions to the team. And one is, looking at your cohort of 44, were there any comorbidities that these patients had? And what effect did that have on the, the outcomes that you've had? And the second question is, are there any predictive or preoperative factors that if you look at your cohort, you'd say this contributed to them developing the immunotherapy-induced pneumonitis, even though it's very rare? I was just curious if any of that data came out of your cohort. Thank you. Thank you for the talk.
So, sorry, I did not catch you. Could you speak slower?
Oh yeah, okay. So the first question is, are there any comorbidities that your patients had that contributed to the
in this patient, in this case?
Yes,
in
or
this case,
the other patients
right?
that you see. Yeah.
Oh yes. Oh, thank you. So let me try the first comorbidity. Of course, I think if we are going to use immunotherapy, I think when the patient has some rheumatoid or some like diabetes, I think the patient may be unfit for the neo-adjuvant immunotherapy. Because if for this patient you use immunotherapy, it may disrupt the immune system of the patient. It may cause some complication. So the second question is?
The second question was, looking at your cohort, I think you mentioned the 44 patients.
Yeah.
Are there any preoperative factors or predictive factors that can contribute to developing pneumonitis after immunotherapy?
You have any preventive measure?
Prevented. Prevented. Yes. So in my opinion, I think we could take several measures to prevent the pneumonitis. First, during the surgery and after surgery, we pay attention to control the intravenous volume. Usually, during the surgery, it takes us around 4 hours. We will ask the anesthesia to control the intravenous volume less than 2,000 ml for the patient. Because I think if the patient get more burden from the intravenous, then there will be more possibility the patient will have pulmonary edema. The second question, we will use antibiotics. Sometimes if for the older patient or for the patient with diabetes, or for the patient with long-time smoking history, we will even use the empiric antibiotics. And the third point, sometimes we will use the gamma globulin because I think the globulin will block the T-cell receptor so as to decrease the inflammation level. Thank you.
Okay. Any comments from Professor Reader?
Yes,
Hello?
Thank you very much. Hello, can you hear me?
Okay. Yeah.
I've got a couple of comments and a couple of questions. But first, I'd just like to say I've got no experience with immunotherapy in the neo-adjuvant setting. In Australia, we just give it in the palliative setting. So I've never had to operate on such a patient. But I guess I'd just like to congratulate you on partaking in this study and sort of pushing the boundaries in developing new therapies, because it's clearly a key area that we need to sort of further develop. And I guess in this great presentation. You've highlighted a number of key issues, and I suspect you may never know the true cause of the pneumonitis in this case. I mean, it seems to be like a process, a diagnosis of exclusion mainly, but I certainly think it's probably a testament to the quality of your anastomosis that it survives such high dose steroids. I'd be very scared as a surgeon giving the patient such high doses. I guess the two questions that I had mainly relate to the translational aspect of your study. So are you exploring any therapeutic biomarkers to try and determine which patients will benefit from the immunotherapy? Like, are you looking for tumor infiltrating lymphocytes in these patients? And also, are you assessing the patients for their response prior to surgery, whether that be clinically or metabolically on a PET scan or MRI scan? So they're the two questions just relating to the, I guess, the setup of the study.
Thank you, Professor Ray. Yes, for the patient, when we are trying to use the steroid, we are really conscious whether we will maybe because in the steroid, first we need to exclude the patient has no bacteria, pneumonia, or otherwise we will make the situation even worse. So when we're using the steroid, we still use the empiric antibiotics. We are confident that because at the beginning we made the sputum culture for several times every day, once every day, but all the result is negative. And the PCT, you may notice the level of the PCT is always less, very low. So finally we decide to try the steroid. And I do agree with you. I think when you are using the cortic steroid, you should be very cautious about whether maybe it will cause another serious infection. Sorry, the second question is
just related to what you're doing in terms of the data you're collecting and the tissue.
Oh yes.
Are you looking for like the tumor infiltrating lymphocytes maybe as a biomarker to see who would benefit from this treatment? And
yeah,
are you assessing for any response before you operate to see if you get a good correlation with that, say with a PET scan and your pathological assessment?
Yeah, but it's a part of our password, especially when we are conducting the trial of neu-105010. We noticed that PET-CT is maybe less of use in this field. But we do notice that, and we published a study that MRI could be useful to predict the or evaluate the response of neo-adjuvant therapy. But it's very difficult to correctly judge whether the patient achieves PCR or not. I think it's the key point. So up till now, we still think that surgery is the gold standard, and it's very necessary to evaluate the response of the patient. And in our clinical trial, we are also planning to do some translational research, but it's still going. But there is one, I think it's very common difficulty is that because before the treatment, it's hard to obtain enough sample to carry out this kind of research. Thank you.
Okay, thank you. Any comments from Professor Morning from Geneva?
Yeah, thank you very much, Professor Mao, to be invited and to have the comments. I had a problem with my microphone at the beginning. So I think first it is a very interesting case because of the neo-adjuvant treatment with immunotherapy is probably one very important part of treatment in the future. For the moment, it's experimental. We have the data from the adjuvant treatment, and we are doing in Switzerland now the adjuvant treatment according to the checkmate, and we have very good experience with that. and probably not problems with pulmonary diseases. This is one point. I think the pulmonary problem you have is probably multifactorial, and I'm not sure that it's really by the immunotherapy induced, but it's possible. And what we have seen in the palliative treatment with immunotherapy, it's indeed especially a very good effect for lymph node recurrency. So this is, I agree totally, we have seen this in the palliative treatment. So it's a very interesting case, and we have to wait for the results in the future.
Okay, thank you very much. Any comments from Professor Li Ying?
Professor Bonnet, I think, has a question.
Yeah, I've got a question or a comment, if possible.
Any comments?
Yeah, one more comment. I would like to ask you, we have participated recently on a phase 2 trial, which name is NeoNIPIGA. I don't know if you know it. It was for adenocarcinoma of the esophagus and the stomach, and only for adenocarcinoma with deficient mismatch repair. And in this phase 2 trial, there was immunotherapy for neo-adjuvant period and for adjuvant period. It was nivolumab and ipilimumab. And we were struck to see that there were more lymph nodes surrounding with a kind of huge inflammatory tissues. Was it the same for your case after the immunotherapy? Did you notice changes as regarding the lymph nodes, or was it the same as usual? What do you think about that?
Thank you, Professor Bonnet. It's a very good and detailed question. We do notice difference in the lymph node and in the tissue reaction, especially compared with neo-adjuvant CRT. Because we know that after neo-adjuvant CRT, all the data from all the trials show that fewer lymph nodes were harvested after neo-adjuvant CRT. Because I think it's because the lymph node will shrink usually after chemoradiation. And meantime, the lymph node may melt, so that will cause the decrease of the lymph node number. But if we use immunotherapy in the neo-adjuvant therapy, I think it's different. We do notice the lymph node will enlarge, and maybe more, I think, maybe more vascular around around the lymph node, and the number of lymph node harvested will increase. I think it's due to the increased immuno effect. Yeah, and to some degree, it brings us more difficulty during the surgery. Also give us more challenge, but I think we can handle.
Thank you very much. I experienced the same. Thank you very much.
Thank you.
Okay. Is there any comments from Professor Li Ying and Professor Wang Zhen? Are you there?
Okay. Thank you, Dr. Mao. I have one question for Dr. Yang. It has been reported that the combination of radiotherapy with immunotherapy may increase the risk of pulmonary toxicity when compared with CRT alone or immunotherapy alone. A study from Korea named ACTS-29 also combined NCRT with PD-1 inhibitor, reported 80% of ARDS and 12% of ARDS-related deaths after esophagectomy. However, another study, the PALIS study from Shanghai, China, and perfect study from Netherlands also combined CRT with immunotherapy, did not show a high incidence of pneumonia or ARDS. So my question is, what accounts for such a wide variation in incidence of pulmonary complications in different trials? Did it correlate with the radiation field? We know, as we all know, different centers maybe have different radiation field.
Thank you, Professor Wang. I do agree with you. I think in this point, the radiation field is very important. And in our center, the radiation field will cover only the primary tumor with the suspicious lymph node. We will not extend the radiation field to the net prophylactic. In other words, we will not perform prophylactic radiation because we try to decrease the radiation field, just like you say, to prevent even radiation-related pneumonitis. I think nowadays all the ongoing trial are small sample, phase one. You know, the Paris one is actually the phase 1B trial, and phase 2 the Korea trial. The sample, I think, is not enough to evaluate the toxicity stably. If we have around 100 cases, I think at the time we can objectively to evaluate the side effect. Thank you.
Thank you. Okay.
Okay. Is there any comments from Professor Li Ying? Professor Li, are you there? Okay. Thanks to Ward, thanks to reporters and to all the discussants, and then we have a very interesting case and a very interesting discussion, and thanks to all. And I would like to hand the microphone to Professor Yu for the case 2 discussion. Professor Yu?
Hi, I'm here.
Okay.
Thank you, Dr. Mao, and thank all the speakers and comments from last case. And now we prove to the next case. This case is very interesting. It's not about the esophagus cancer. It's about esophageal injury, a small kind of injury, just by a small fishbone, and maybe it can cause very heavy or serious injury to the esophagus and the structures around the esophagus. And let's invite the team from Dr. Tan from Shanghai Zhongshan Hospital. The speaker is Dr. Chen Zongwei. Dr. Chen, are you there?
Yes, I'm here. Can everyone hear me?
Okay, so let's begin.
Yeah. Sure. And can you see the slides, everybody?
It's going, yes.
Yeah, yes. It's on the screen. All right. Hi, everyone. This is Dr. Chen from Zhongshan Hospital, Shanghai, China. I'm really honored here to give you my speech. Unlike the first one, my case is much more simple and may not raise that much question, but still very interesting. The topic of my speech is Hi. Is it okay now?
Yeah, back again.
All right, sorry. So the topic of my speech is from intraluminal to extraluminal, the removal of an unusual esophageal mediastinal foreign body. The abbreviation of foreign body is FB. Of course, obviously, the FB here is not Facebook, but foreign body. This is some picture of the typical foreign body, and the ingestion of the foreign bodies, especially animal bones, due to accidental swallowing, careless chewing, And self-harming is one of the most common endoscopic emergencies throughout the world, especially in China. The prevalence of ingested foreign bodies depends mainly on patients' age, cooking methods, and the food culture of the population. And the foreign bodies can be animal bones, pills, bottle lids, and even false teeth. And this prevalence is likely due to particular Chinese dietary habits. Fish, chicken, duck, and other meats with ingestible bones are very popular here in China. And these large animal bones frequently cause impaction when ingested. Sharp animal bones were also the primary cause of the esophageal perforation. Fortunately, most of the esophageal foreign bodies can easily be removed by skilled endoscopists thanks to the development of endoscopic techniques, and only 1% or less require surgeries, including those foreign bodies with sharp ends, which penetrate the esophageal wall, causing perforations and remain in the mediastinum space. Those perforating esophageal foreign body may cause very, very severe complications, including bleeding and migrations and so on. Traditional approach can be surgeries through cervical skin incision. However, for those foreign bodies which penetrate in the thoracic esophagus, which is more than 20 centimeters away from the incisor, cervical approach might not be effective either, and surgeries through chest wall will be inevitable. In our case, we tried a novel minimal invasive approach instead of traditional transcervical approach or thoracotomy with the help of the mediastinoscope. The patient was a 65-year-old woman who swallowed a fish bone 10 hours before she was admitted to our hospital with a substernal pain. The CT scan showed upper thoracic esophageal perforation caused by a foreign body. The distal end of the foreign body is at the level of the aortic arch. As usual, at the very first, the endoscopic ultrasonography was performed to locate the foreign body, and there was a suspected foreign body outside the esophageal wall and was adjacent to the upper edge of the aortic arch. And in the view of the normal endoscope, at 20 centimeters away from the incisor, a longitudinal ulcer with the length of about 8 millimeters can be seen. Using the hook knife to cut the esophageal wall along the erosion focus and expose the submucosal layer and muscularis layer. But unfortunately, after some very careful examination, no foreign body was found. After hemostasis with hot biopsy forceps, the wound was closed with clips. So the surgery was inevitable and was in need. The patient was placed in a supine position under general anesthesia with bilateral lung ventilation. A 5 centimeter incision was made about 1 centimeter lateral to the sternocleidomastoid to avoid collision with the platform of the port. A lap protector with matched retractor inserted with 3 trocars was inserted into the cervical incision. The operator stands on the left side and the assistant stand on the right side of the patient. Carbon dioxide was inflated at the pressure of 8 millimeter Hg into the mediastinum to establish the operated field. Because it was extremely difficult to perform within the limited mediastinum space, a deflectable laparoscope provided by Olympus was used as a mediastinoscope to ensure the maximum surgical view for the operator. The operator first inserted a ligature Maryland gel held in the right hand into the upper mediastinum under endoscopic vision, and then inserted a suction stick, which also acted as a retractor held in the left hand into the upper mediastinum to provide countertraction on the operated field and remove smoke produced by ligature. In the meantime, the assistant surgeon controlled a 5 millimeter Olympus deflectable laparoscope. The mobilization of the upper thoracic esophagus was then performed, starting from the left and posterior side of the esophagus. Before reaching the aortic arch, the tip of the fishbone was found in the mediastinum. A dissecting forceps was used to remove the whole fishbone from the mediastinum. The incision was closed after a drainage tube was placed at the surgical field. The patient was discharged 2 days after the surgery and had a very speedy recovery. In this case, we actually inspired by the mediastinoscope and laparoscope-assisted esophagectomy. We use the minimal invasive transcervical approach with the help of deflectable laparoscope to remove the foreign body in the mediastinal space. The preoperative workup is very crucial because it's important to locate the foreign body to investigate the relationship between the foreign body and the surrounding. And CT scan is quite useful to identify the location, the shape, and the nature of the foreign body. And that's all for my speech. Thank you so much for your attention.
Thank you so much, Dr. Chen. You give us a very important case, a very interesting case. And although it's not very often happened in some of the tumor hospital, I think some of the doctors from the tumor hospital, they don't have this kind of experience on this foreign body injury, the esophagus. But personal opinion, I think our doctors from the general hospitals, you must have a lot of experience about this. So let's have our discussion and questions. Are there any questions from our Chinese colleagues?
Okay. Professor Yu, thank you very much for Dr. Chen gave us a very excellent case, and congratulations for this success case. You know, for your this kind of skill, the transcervical mediastinoscopy, MIE, it is relatively a novel skill in recent years, especially in Japan and in China. Some parts of hospitals, they will perform this kind of surgery. And I have two questions for you. And the first question is, for this kind of patients, when you do the surgery, you must expose the space for their anatomy or dissection. But I want to know, will this narrow space increase the risk for the surgery? Okay, this is the first question. And the second question is for the esophageal cancer. And you also mentioned you will perform some esophagectomy by this skill. So what is the indications when you use this technique for the esophageal cancer patients? Thank you.
Okay.
Okay. Okay, thank you very much for the question. And the first question about the risk, of course, the risk is quite high because there's very limited space in the mediastinal space. So we inflated the carbon dioxide into the space. So the mediastinal space is, expand due to the inflation of the carbon dioxide, but still it's the space is quite small. So that's why we use a kind of new endoscope technology, which is a laparoscope, deflectable laparoscope, and this can provide maximum vision for both the surgeon and the scopist. That's the first question. And the second one, of course, we have done like 20 something cancer, esophageal cancer in the recent 6 months. And our indication, because as you have mentioned, the surgical space is very limited and the view is very poor. So the harvest of the lymph node is not as good as the normal McNeil surgery. So our indication is very early stage patients with no lymph node metastasis. That's the first one. And the second indication, and which is quite important, is the patient who have already undergone thoracic surgery. So there must be adhesions in thoracic space. So that's the two main indications for our mediastinoscope assisted transcervical esophagectomy. Thank you, Dr. Leng.
Thank you. Thank you very much.
Okay, thank you, Dr. Long, and thank you, Dr. Chen. And
Dr. Yu, could me ask a question?
Yes, sure.
Yeah, thank you, Dr. Yu. Thank you, Dr. Chen. This is a wonderful case from Zhongshan Hospital. Very interesting. I ask 2 questions. One is the indications for this case, the foreign body, maybe the mediastinum is with not serious infection. I mean, if
Yes.
we meet the patient with foreign bodies or Boehingham syndrome with serious mediastinum infection, large abscess, could we use this technique to treat the patient? The second question is, in our normal clinical work, we often to use an intraluminal skill to take off the foreign body. I mean, if the foreign body's location, for this patient, the location is upside thoracic. I mean, if the foreign body is located in the lower part, shall we use this technique? And the third, I mean, from your experience, I want to say, if we can use STIR, submucosal channel skills to open the window of the esophagus muscle to get out to the mediastinum to take off the foreign body, because this is no scar in the neck, at least. Okay, thank you.
Thank you so much, Dr. Guo, for your question. And this is a very good question indeed, because as I have mentioned in my speech, the patient was admitted 10 hours after he accidentally swallowed a fish bone. So there's no serious infection through our CT scan. So CT scan prior to the operation to evaluate the risk is very important. And it's quite, and have reported by many Japanese experts and Chinese experts the importance of the CT scan. So after we see the CT scan, we saw there's no serious infection and abscesses in the mediastinal space. So that's why we use this approach. And if we see many abscesses and a serious infection, we might not take that approach, because that approach, we might not have a clear section of the abscesses, and maybe we will not have a satisfactory, drainage after the surgery. That's the answer to the first question. And the second question is, if the foreign body is in the lower part of the esophagus, it's true, but we haven't encountered the foreign body in the lower part, but maybe we can have a try next time, because when we do esophagectomy, we dissect the esophagus way down there. So I think that might be possible for us to use the same approach to retrieve the foreign body. That's the answer for question 2. And the answer for question 3 is the position. It mainly depends on the position of the foreign body. If it locates in the left side or the posterior side of the esophagus, the approach mentioned in the speech might be effective. But if it's on the interior side, maybe the way you've mentioned is more effective. Thank you very much.
Okay. Thank you, Doctor.
Sorry, Dr. Yu.
Yeah,
Could I
Doctor.
make some comments? I think that Zhong Wei did not get the meaning of Dr. Guo's third question. Actually, the question is, Dr. Guo's question is, why do you not use the tunnel skill, like submucosal tunnel, by the endoscopist to move out to the foreign body? Actually, the endoscopists try that route, but they can't find the bone in this case. So, we tried after our endoscopist, and they close the mucosa with a clip. So for this special case, also we have some risk because the mucosa is opened and then closed by the clip, and we open the mediastinum space. So I think this is another risk for this special case. That's all.
Yeah,
Thank
sure. And I think maybe it's very important for this kind of foreign body to localize before the operation. But actually, during the operation, you have the gas pressure to the mediastinal, the very small, the narrow space, and this pressure, I think maybe can move the foreign body to other part. So I think how you do it to localize the foreign body in this narrow space.
Actually, like you mentioned, it's not so easy to find the fishbone. We tried several times, and luckily we found this bone. And I think we use a very low pressure to carbon dioxide pneumonitis. So and it's lucky. Sometimes I think maybe it's very difficult to find this foreign body in the mediastinum. Even sometimes even we do a thoracotomy, it's not easy to localize the foreign body.
Yeah, sure, I agree. And it seems like Dr. Bonnet, you have some comments or some questions?
Yeah, thank you. Sorry.
Yeah, sure. Please. Dr. Bonnet.
Okay. Thank you very much for this this case. Very interesting. I'm not used to do such surgery. I have two questions and one comment. So first, about the location of this fishbone. This fishbone has perforated the esophagus, and to your opinion, it is due to the aspect, to the form, and due to the constriction of the aortic arch, because I remember the frequency of perforation is very low. So it's my first question about the location. And the second one, and people asked about that, such a technique can be used immediately after ingestion, and when there is a serious infection, you mean it's not mandatory to do such a mediastinoscopy? And my comment is the surgeon was familiar with mediastinoscopy, I hope. And regarding the feasibility, without deflectable laparoscope, is it possible to? Thank you very much again.
Okay. Dr. Tan, you answer this, or Dr. Chen?
Dr. Chen?
Yeah. Oh, okay. First, the answer for question 2. Actually, this is a very brilliant idea by Dr. Tan, because we have discussion every Wednesday morning at 6 o'clock in our office. Everybody will come. Everybody in our department will come to a meeting room and to discuss some interesting cases and some complicated cases. And very coincidentally, this is a patient admitted the day before that, the night before that. So the doctor in charge discussed and shared this case with all of us. And Dr. Tan said, we can do this that way, because before that, we have done like a dozen cases about the transcervical approach, mediastinoscope and laparoscope-assisted esophagectomy, because it's quite similar process as the former operation. So that's inspired by the esophagectomy. So we use the same approach to take out the foreign body. And I truly forgot the first question. I'm sorry.
it was about the location of the perforation. I mean, the perforation is a very rare event. And yes. I was wondering if it is due to the aspect or the form of the fishbone, or due to the location in the area of the constriction of the aortic arch. What do you think about that?
Actually, I have no idea. Maybe God knows.
Okay.
Very hard for me to answer.
Yeah, you don't know. There is no explanation.
It depends on who you trust, the God or the Buddha. I don't know.
Okay. Okay, I would choose.
Okay. Let's trust both of them. And Dr. Chen, I think you have some comments.
Okay, thank you so much. Congratulations of Dr. Xiao Chen and Dr. Li Jie, Dr. Tan. So great. So I have a stupid comments and questions. Just leave behind inside of a bone, nothing to do. 会怎么样的？啥都不做怎么样？
Maybe
there's going to be sepsis, local sepsis, and finally penetration and erosion into the aorta.
If without inflammation, without infection, just there, bone.
But it's not definitely a lethal condition, but most often than not, the patient would be more, in a more severe condition, like hours later, because the success of this case depends on timely intervention. The patient went to the hospital 10 hours after the ingestion of foreign body, and then the doctors did a wonderful procedure to take the bone out.
So I mean, yeah, I do agree with your opinions. But what's the time windows to make the decision? Do we have some observational time to decide to make the decision, just leave it behind, or do some of the surgery like the Dr. Tan's procedures is a great procedure indeed.
You don't want to sacrifice a single patient.
Yeah, you're right.
Yeah. Yeah, actually, I have the experience. One case, I think it's a young gentleman. It's a friend of a husband. He has a very similar situations, but he misdiagnosed lung cancer because there is a shadow of the right up lobe there. But people have some very short time, the fever, a cough, or something like that. But the patient visited me, I think 3 months after the history of swallowing the foreign body, something like that. I just take some of the examinations for PET scan or CT scan to just observe. Finally, the patient keeps there without any procedures and some any treatment. So,
okay, thank you, Dr. Chen. And I think Dr. Morning, you have some comments.
Yeah, first I want to say a big congratulations because of this was excellent job, and I think there is no standard treatment. It's a very individual decision for this case because of the localization was not totally cervical. It was in the mediastinum a little bit deeper, and it's difficult to find it. Absolutely, I think, and because of it was very early put out after the perforation. There was no infection and other things. So congratulations again. And it's really an individual approach, and I think there is no standardization possible.
Yes, yes, Dr. Mo.
Yes.
Dr. Mo, you're right. And Dr. Tai, are you there?
Yeah.
Yeah. To my personal opinions, and Zhongshan Hospital, you have a very, very strong endoscopic center, right? And Dr. Zhou Binhong told me that he can do everything through the esophagus wall, and can resect a lot of things. And how many percent of this kind of patients with the foreign body into the esophagus, you need to intervene by surgical procedures?
As you mentioned, that our endoscopics is very famous, and so always lots of emergency or foreign bodies sent from outside to our hospital. But actually, maybe less than 10% maybe need a surgical remove, I think. But I haven't have any statistics. Maybe less than 10%, I think it's possible. And always we do, now we always try our best to do this procedure minimally invasive, use the thoracoscope or laparoscope, or just from the cervical incision. Yeah, even for upper mediastinum foreign body, I think transcervical procedure is sometimes makes sense. Yeah, but it depends. Yeah, and also we have lots of, like Dr. Fang mentioned, like some mediastinum abscess and penetrates the aorta, even with the very severe hemorrhage. And we deal with our cardiac surgeons to do the very big surgery, even take place the descending aorta, or with the second procedure to do a reconstruction of the esophagus using a collar interposition like this. And yeah, so this is, I think, I have another comments for Dr. Zhongwei's one answer. He answers that it's if there is a mediastinum infection, we can't use this this procedure. I think we can try. Actually, I have tried some drainage of the mediastinum infection. Use the typical rigid mediastinoscope. I think it's effective, and we can see the mediastinum structures and the evaluation of the infection, how severe the infection is. And also we can put a drainage through the cervical. If the patient has a complete mediastinum pleura, I mean the mediastinum pleura is not erupt. So we can just use the drainage through the mediastinum. It's very effective. So I think it's also can use, but maybe it depends on case specific. So for every patient, we must do a careful evaluation and use a specific technique to do for each case. So that's my comment and opinion. Thank you.
Okay, thank you, Dr. Tan. And Dr. Fang, do you have some experience from Shanghai Chest Hospital?
Well, I would echo Dr. Tan's comments that mediastinoscopy is often helpful in such cases, even if there's some sign of mediastinal infection. To me, it seems the only contraindication to such cases would be if the patient already have some sign of aorta erosion or near rupture, that would be very dangerous because, like Dr. Tan put it, at such circumstances, the mediastinal pleura is intact. There's an abscess in the mediastinum. Actually, such abscess has a great tension that compress the aorta.
Yeah. Hello. Dr. Fang, you're online or offline? 老方掉线了。Okay. Okay, Dr. Reed, do you have some comments about this case?
Well, just that it was probably very well managed. I mean, I would have done a similar thing initially, trying to manage it endoscopically, and I would have approached colleagues with EUS and probably the ESD or POEM skill set, which I don't have. But I agree with a lot of the comments that I think the case shows that you can transfer skills from other operations to help with these sort of emergencies. And we've spoken about the esophagectomy skill set. And I know Richard van Hiligsberg was in this audience, but when I was with him, he was working with Peter Grimminger and Jan Hendrik Egberts from Germany. They were doing cadaveric workshops using the single port robot, getting exposure from the neck and doing cadaveric workshops. So they were developing their skill sets for an esophagectomy. But I know my thoracics colleagues, they also do operations like video-assisted mediastinal lymphadenectomies, or the TEMLAR approach, the total endoscopic mediastinal lymphadenectomy, which give a very similar view and approach in terms of the anatomy. So I think, yeah, you have to draw on your resources and use the expertise and skills you have from these other operations. I guess one just question, during the operation, do you also have the endoscope in the lumen of the esophagus, maybe transluminating or something, so you have a landmark to sort of identify where structures are?
Yeah, thank you, Reed. And Dr. Chen or Dr. Tang?
陈宗伟，你回答一下吗？
Okay, during the surgical process, we don't have endoscopists in our surgery room because the wound is closed with the forceps, and we can locate the foreign body by the CT scan, not intraluminally. So there's no endoscopists in the operation room when we were doing the surgery. Thank you, Dr. Reed.
Okay, thinking more like parking it at the, if you set the endoscope at the level where you thought the perforation was, the light from the endoscope might give you an indication as to when you're at the correct level. This is if you couldn't see the foreign body directly, you knew you would be at that roughly the correct spot.
Yeah, great idea. Maybe we can try next time if we have a similar case.
Yeah,
Thank you.
Yes, I think you will have very soon. And Michael, do you have some comments?
Well, Michael's the international expert on esophageal foreign bodies.
So. Thank you for the kind introduction. I think that was a fantastic case. I really enjoyed looking at how you managed it. And one of my comments was connected to what Matt just talked about, having the scope in the lumen, because sometimes for us, we would put in an NG tube and pass some methylene blue to help you see on the mediastinal side where the dye comes in. The second issue is what has been addressed by someone else about the flexible mediastinoscopy. And for us who only have, like the rigid, what other options would have? So I think that would be my question for you. For us in Africa and other places where I think the closest I would be to improvise and pass through the laparoscope, like a flexible pediatric scope with a grasper to grab the foreign body and then pull it to where I can switch to the laparoscope and, mediastinoscope and grab it and pull it out. But otherwise, I think time to presentation is what we struggle with here. Many patients, I think the last one we removed was dentures that had eroded proximal cervical portion, eaten through the wall and into the mediastinum. And we didn't even know there were dentures until we flipped to open the chest. So thank you so much for sharing. I've really enjoyed listening to this presentation. Thank you.
Okay, thank you, Michael. And I think you have given us a very good idea. And Dr. Tan, how about to use the endoscopy inside of the mediastinoscope or the laparoscope?
You mean use the endoscope?
Yes.
Yeah, actually, you know, another doctors from my division, he tried use the endoscope to mobilization of the esophagus combined with our endoscopist. And they tried maybe 12 or 13 cases, and all cases are get smoothly performed. But the question, the problem is how to do lymph node dissection under this flexible endoscope. They do some.
I mean, in this case, I mean, in this case,
it means
to pick up the foreign body from the next to the esophagus.
Use endoscope. I don't know the case volume, but they have some case reports. You can see they publish their case report on some special endoscopic magazines, and maybe several cases. But I don't know the number. Yeah,
maybe it can work. And Dr. Yang Hong, do you have some comments? Although you don't have so many this kind of cases in your department.
No, thank you, Professor Yu. I do agree with Dr. Ray, because we don't have experience about the foreign body, but we do perform one case about the leiomyoma, because it's not so big and not so small, and the location is a little embarrassed because on the level of the subcarinal. So for that case, after the consultation in our team, we decided to use endoscopy and thoracoscopy to take out the leiomyoma. And during the process, we do think the endoscopy is very useful for the thoracoscopy to identify the location of the tumor. Thank you.
Okay, thank you, Dr. Yang Hu. And is there any comments or the questions to the speaker? No. And let's invite Dr. Tan Lijie to have a small summary for this case.
I don't think I have any. I need to do some summary. Yeah. I think the new technique gave us more choice to do surgery. So I think with the development of the scope or even the robotic system, we have more choice, and we can get more. We can get more precisely to give less trauma to our patient and get a very good result, both either for the malignant cases or for these, like this case, the benign cases, the benign disease. So I think for surgeons, maybe we may try. We need to try more new techniques for very senior surgeons, because this is a new era and a new technique and idea we must learn from each day. Yeah, that's all for my comment. Thank you very much.
Okay, thank you, Dr. Tan. And I think let's end our case 2, and let's move to Nicholas
Thank you. I think we can now move to the conclusion. I'll hand it over to Robert for a few words.
Okay.
Okay, before that, move to the end, I would like to ask Professor Jie He, are you there? I forgot to ask him to give a conclusion of case 1.
I don't think he's here.
Okay, then we'll give the microphone to the Professor Guni. Make a conclusion.
Robert, you did not take on your mic. Turn on the mic.
Yes, here it is.
Yes.
Yes, my conclusion is very simple because once again, this was a multidisciplinary discussion of an exceptional level, and I thank Professor Mao for the efforts he made for the organization of such beautiful panel and the beautiful cooperation of ideas. And this is a new step. This session is something like a new step in this cooperation that has been established by them, Professor Jie He and Mao, since the creation of our platform, really. Now 7 Chinese pilot centers are now installed on this platform, and they bring the prestige and excellence that reflect our approach. And Professor Jie He, at the beginning of this session, his special address reminded us was with what we can expect from such an effective cooperation as it was today, that is multidisciplinary and at the highest scientific level. And his address set the tone for all that we can expect for the future, I think. These 2 discussions were, of course, recorded. The experience and scientific level of those who composed these panels, and the interest aroused by the virtual floor, by the exchange of different opinions that we had today from Australia, from Africa, from Europe, etc. All this make a combination that allows such sessions to have the necessary, I should say, impetus to further improve this valuable tool operated by the OESO-SEMPIRE platform every month and for the scientific community. Well, I should say that the next clinical case will be proposed next month from Harvard, this time by Professor Hiroshi Mashimo. He is our current president of OESO, and this will certainly be another event, details of which will be given in our next newsletter. And now, simply I would like to end on a personal note. As usual, Frederick, the president of the OESO Foundation, who set up the technical support for this session, and I convey my thanks to him. But today, in order to compensate for the risks of a possible absence imposed by his profession, he called upon to provide additional technical support. As you see, Dr. Lang from the Sichuan Cancer Institute, along with his brother Nicholas from London, that appears here, and also his wife Isabel, in case of Nicholas would have to leave in the middle of the session. And I am glad to welcome Isabel here, à laquelle je suis très heureux de souhaiter aujourd'hui une bonne fête, because it is today a special day for all girls and women called Isabel, and Isabel is her name. To all 4 of them, I address my motivated thanks for what they have just allowed us to share. Thank you for your presence and looking forward to our next discussion. Thank you to everyone.
Okay, thanks to everybody.
Yeah, thank you very much. Bye-bye.
Bye-bye.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye-bye. Bye-bye to everyone.